I'm Tara Haelle. I am the Health Beat Leader on infectious disease for the Association of Healthcare Journalists. AHCJ is the largest organization of health journalists in the US and does not accept funding from any corporate interests, including pharmaceutical companies. This webinar, hosted in collaboration with the expert vaccine analysis team, is one in a series of topic-specific training opportunities to brief health journalists and apparently these days many other people on the latest information in a particular health area. A recording of this webinar will be available this afternoon. Everything that is said today is on the record and available for being quoted elsewhere. Today's topic, big changes to the CDC's childhood vaccine schedule, what you need to know. Joining us today are Jesse Goodman, an attending physician and the former FDA chief scientist, and now a professor of medicine and infectious disease at Georgetown University. Sean O'Leary, a professor of pediatrics and infectious diseases at the University of Colorado School of Medicine. John Grabenstein, president of Vaccine Dynamics and retired director of the U.S. Military Vaccine Agency. And Dorit Rice, a professor of law at UC Law San Francisco. As we discuss and hear from these speakers about changes to the immunization schedule for children and how these changes, what they mean and how they've bypassed appropriate protocols, the guests will then answer questions. Questions can be asked at any time, although we'll get to the after each of them have spoken, we'll actually go through them, but they can be done by typing into the Q&A space. That's the question mark at the bottom of the Zoom frame. You will not be able to type into the comments section in the right there or the chat. So you need to use that question mark to enter your Q&A. I'll direct the questions to our guests. All right, thank you again. And we're going to go ahead and get started with Jesse. And I am going to pull up some slides for Jesse. Okay, go ahead, Jesse.
Okay, great. Thank you so much. Well, I really appreciate everybody joining us today, and it's really a pleasure to be here with my colleagues and with AHCJ. I wanted to emphasize, and I know Sean will feel the same way, that what we're talking about here is not theoretical. This is real, and people's lives are impacted by the diseases that have been affected by these recent changes. Sean will go into this in more detail, but they include meningococcal disease up here on the left, which can be treated with antibiotics, but despite treatment, a substantial number of patients still die, and many are left with long-term disability. COVID-19, where fortunately there's immunity in the population, but not in our youngest children, and both adults and children still are hospitalized and die of COVID. Influenza, we're in the middle of a very intense outbreak. We still last year had 45,000 children hospitalized and 288 died. Rotavirus, which is usually self-limited, but can cause severe diarrhea, vomiting, and dehydration, and has resulted in 50 to 70,000 hospitalizations a year in the US. And then the two major hepatitis viruses for which we have vaccines, hepatitis B, which we've talked about before, but before the advent of universal vaccination at birth dose, there were up to 10 to 20,000 cases in the first 10 years of life. And this resulted in a quarter of people developing cancer or cirrhosis, which is a terrible outcome. And then finally, hepatitis A, again, usually self-limited, but where we used to see thousands of cases in children, including daycare outbreaks. So these are real people, real children, real adults, real effects that these vaccines, we have all taken for granted that they've been reducing. Next slide. So what happened on January 5th? Our speakers, and Sean will talk more about this, multiple vaccine recommendations were withdrawn without any new data. And these are vaccines, as I mentioned, with long records of benefits exceeding risks and support from prior CDC advisory committee on immunization practices. The justification given was rife with cherry picking and innuendo, with statements such as that hepatitis A vaccine had benefits that were limited, which is not true. The benefits are preventing the infection, but again, no actual analysis on risks and benefits. This will definitely cause confusion, indecision, and general erosion of confidence. And as a result, access will be reduced, particularly for the disadvantaged, and fewer people will be immunized, resulting in more disease transmission and outbreaks, hospitalizations, and deaths. So we're here today as part of a community to say that journalists, healthcare providers, health and pharmacy systems, and public health have an opportunity and really a responsibility to share accurate information and science-based recommendations. We're going to need to monitor and support access to these vaccines for our communities and patients. And we're also going to need to pay attention to tracking disease, particularly when we're seeing the administration start to reduce reporting, for example, to CMS on vaccination rates. And with that, I'm extremely delighted we have Sean O'Leary and happy to turn things over to him.
Thank you, Jesse. I will pull up my slides here. All right, confirm that you are seeing this. Great, okay. All right, thanks. So I'm just going to briefly level set here. I think others will talk a little bit more about this, but just the normal process for U.S. vaccine recommendations. So this is not a slide I created. This is not new. This is over 20 years old, but was true really up until recent events of how vaccines are recommended in this country. I won't focus on the top of this slide. That's the pre-licensure work. But once a vaccine is licensed by FDA, it then goes to CDC for consideration, and that's where the Advisory Committee on Immunization Practices comes in that advises the CDC director. Once the CDC director signs off, it goes into the MMWR and then leads into uptake and financing. And I think very important that this gets confused a lot. These are simply recommendations. These are not requirements. These are not mandates. At the same time, and I'll come back to this in a minute, the Committee on Infectious Diseases, so I am currently the chair of the Committee on Infectious Diseases for the American Academy of Pediatrics, historically has also made recommendations for vaccines. I'll talk a little bit more about that in a second. But we publish our own schedule as well through a very similar process of advising the AAP Board of Directors. Our schedule is then published in Pediatrics. Moving on to what happened Monday, I'm going to go into a little bit more detail from what Jesse just shared. So, the excuse, of course, was aligning with peer nations. So this was an unprecedented move. The politically appointed leadership of HHS announced major changes to our schedule. And these most closely aligned with the schedule of Denmark. During the press conference, they called the US an outlier. In fact, Denmark is really among developed nations the outlier. The US schedule is similar to quite a few other countries. I list a few of them here: Canada, Ireland, Germany, Australia, New Zealand. And in a deeply ironic statement, the reasoning given was to restore trust in vaccines. And I think we all know how false that is. There was, of course, universal opposition immediately from medical and public health societies. Lots of analogies that were given in interviews, like comparing a cruise ship to a kayak, a jet engine to a toy plane, putting a square peg in a round hole, outsourcing US policy to Denmark, like setting our thermostat based on the weather in Denmark, and like comparing traffic laws without comparing roads. These are all very apt analogies to what just happened. So what did they do? So this is the immunization schedule that was put out by HHS, showing the routinely recommended vaccines. I won't go into these since these didn't change. Here is something that was quite confusing. It looked like it was a change, but actually in reality it wasn't. They moved RSV monoclonal antibodies into a risk-based recommendation rather than a routine recommendation. But then in the footnote, what it says is that all children whose mother did not have the vaccine should get one dose. So essentially the recommendations for RSV monoclonal antibodies did not change. They just made things more confusing. Now here's where things changed, and I'm going to go into more detail on these, as well as just talk briefly about shared clinical decision making. So this is the list. COVID-19, we already knew that happened last spring. Hepatitis B was in December, but I'll talk a little bit more about that. So let's start with hepatitis A. So prior to widespread vaccination, there were roughly 10.4 cases per 100,000 in the US. That translates to roughly 20 to 30,000 cases a year. Now, there were 100 deaths a year on average from hepatitis A, which is, in the grand scheme of things, not a huge number. But that misses the fact that hepatitis A is a highly morbid disease. It is a miserable disease. For some young children, it can be mild or asymptomatic, but as kids get older, and particularly in adults, hepatitis A can be very severe, often putting people out of work for weeks to months. In recent years, the amount of hepatitis A has greatly decreased. It's 0.5 to 0.6 cases per year. Sorry, per 100,000 per year, or per 100,000, and that's a 17-fold reduction. And we have seen community immunity achieved through widespread childhood vaccination, so circulation in children now is rare. And also in the one of the documents they put out, the low burden of disease currently in the U.S. was cited as a reason for the change, but the low burden of disease is because of vaccination. So that really made no logical sense, like much of what we saw on Monday. So moving to hepatitis B, it's a highly transmissible pathogen, as Jesse mentioned. It causes liver cancer and cirrhosis, and I should say death. Prior to widespread vaccination, there were roughly 20,000 cases of hepatitis B in children every year. Infants can be perinatally infected, meaning infected at delivery if the mother has hepatitis B. That represents about 50% of childhood cases. Infants and children can also acquire hepatitis B from household or other casual contacts, and that represents the other 50%. And that is not, these children are not using IV drugs. This is not sexual activity. This is household contact. In the US today, there are somewhere between 1 and 2.5 million people living with hepatitis B. Somewhere between half and 2/3 of those people are unaware that they are infected. And that's really important because those folks may not be taking any precautions in terms of trying to prevent transmission to others. And then where this really matters for kids, when young children acquire hepatitis B, 90% of those children will go on to develop chronic disease. Of those who develop chronic disease, roughly 25% of them will die from that disease. So this is a really, really highly morbid and fatal disease. In 2023, because of the success of our vaccination program, there were only 7 perinatally acquired Hep B cases in the US. And then moving to why the birth dose matters, we know that routine vaccination is a far more effective strategy than trying to identify risk groups, and we can talk more about that in the Q&A. In the US, roughly 50% or 15% of pregnant women are not actually screened for hepatitis B. On the CDC website to this day, there is the MMWR has shown that from 2015 to 2017, somewhere around 21,000 infants were born to women who were positive for hepatitis B. Of those, though, only 52.6% were identified through prenatal screening. So obviously prenatal screening to identify who's at risk for hepatitis B doesn't work very well. There have been many documented cases of communication errors, transcription errors, and then acquisition of hepatitis B late in pregnancy leading to infant infection. And then importantly, vaccination in that first 24 hours of life by itself can prevent hepatitis B in the infant. And this is one of these diseases, because it's so highly fatal in children as they grow older, one missed case is considered too many. Moving to rotavirus. So before rotavirus was described as, was identified as the virus causing the disease, it was actually called winter vomiting syndrome. Any pediatrician who trained prior to widespread rotavirus vaccination can tell you about rotavirus season. We had flu season, we had RSV season, and we had rotavirus season. We don't have rotavirus season anymore thanks to vaccination. There used to be 50,000 hospitalizations a year with leading to 50 to 100 deaths. These children would come in quite ill, very dehydrated, often vomiting, lots of diarrhea, very miserable disease for all involved. And again, since routine vaccination, we rarely see infants hospitalized for rotavirus, even in unvaccinated infants, because of high community levels of protection. And then, of course, influenza. We've recommended routine vaccination of everyone greater than 6 months of age since 2010. Per the CDC website, again, to this day, in the 2023-2024 season, influenza vaccination prevented 20,000 hospitalizations and 266 deaths in children 6 months through 17 years. Vaccination is highly effective against severe outcomes in children, including ICU admission, death, including in the present season. We had rates steadily increasing for uptake of influenza vaccine to over 60% of children getting an annual flu vaccine through 2021. And then we've seen a sharp drop off to the high 40s since the onset of the pandemic for a variety of reasons. We're coming off one of the worst influenza seasons in over a decade, with 280 pediatric deaths last year, 89% of whom were incompletely vaccinated. And in this current season, it's starting out to be quite severe, with high rates of ER visits and hospitalizations, both in adults and children. Moving on to meningococcal disease, this is the abbreviation for the vaccine that was changed. It's MenACWY. Meningococcal disease is a disease that has very severe morbidity and mortality. It's currently, fortunately, fairly rare in the US. ACIP was actually, before all this madness, ACIP actually was considering changing the recommendations prior to the dismissal of the legitimate members because of two new pentavalent products. We can talk more about that in the Q&A if you want. And the other complicating factor with this change to MenACWY is that roughly 35 states require this vaccine for school. And then the other change was a move to a single dose HPV vaccination and the age of the recommendation. So they moved it to a single dose at age 11. ACIP and AAP had been considering moving to this prior to the dismissal of the legitimate members. WHO considers it as an option. There are several high-income countries that have moved to a single dose, but there are still some unanswered questions. The bigger issue here was the process. There really was no public opportunity for public comment, no review of the evidence to make a decision. And it's also unclear what this schedule change means for vaccinating at age 9 to 10, which was formerly an option with a growing evidence base. And that is currently the recommendation by both the American Cancer Society and the American Academy of Pediatrics. So, and let me just pause for a second and just say, like, all of these diseases I just presented, I'm not sure why, with this move, why do they want to bring these diseases back? None of these are good diseases, but that seems to be the efforts of the administration. So let me talk briefly about what's wrong with a shared clinical decision-making recommendation. Jesse mentioned this a bit, and I think Dora will go into it in more detail. For one thing, clinicians really don't like this type of recommendation. There have plenty of qualitative studies showing that, and there have also been a number of surveys showing that. It's not easily implemented. And the fact is, clinicians already do this. This is what pediatricians, family physicians, nurse practitioners, physician assistants, we do this all day, every day when we talk with families about vaccines. So moving a vaccine into this category doesn't really change the fact that we already talk with families about this vaccines. It just creates a tiered vaccination strategy. We know that it almost certainly leads to lower vaccination coverage because it implies these vaccines are less important. It's very confusing to have these tiered recommendations. We know these types of discussions tend to take more time than routine recommendations. There's also there's a lot of concern about how to document this. How do you have to obtain consent that we're hearing from clinicians? Another really important issue is that some clinicians may not stock vaccines under shared clinical decision-making. We've already seen that with the serogroup B meningococcal vaccine, which is one of the only existing pediatric vaccines that was under shared clinical decision-making. And then, of course, the potential for lawsuits against manufacturers, and I think Dora may talk about that. So let me move into AAP's response. So I mentioned before, so AAP has been making immunization recommendations for children and adolescents since 1935, and we're going to continue to do that. So we publish that schedule every year in pediatrics, usually comes out sometime in the new year. The evidence review for immunizations is an ongoing process, as I mentioned, led by the Committee on Infectious Diseases. This was the response in AAP News. CDC planned to remove universal childhood vaccine recommendations was dangerous and unnecessary. And then we had an immediate letter from the new AAP president, Andy Racine, giving very strong statements on why this was such a bad move. And I won't read this letter. And then this is just to show you, this is our AAP branded schedule. It's really, to me, honestly, a tragedy that we can no longer co-brand our schedule with CDC, but unfortunately, that's where we are right now. And so our schedule is available on our website. and elsewhere. And as many of you know, many states and professional societies are now pointing to our schedule rather than CDC. And then this is just the schedule in a little more detail. And we also have a parent-facing schedule on our parent-facing website, healthychildren.org. So I will stop there and stop sharing.
Thank you for that, Sean. Now we're going to go on to John, and John's going to talk a little bit more about, Sean touched on peer nations, but John has done a deep dive into comparisons to other countries.
My mute button was working. Thanks everybody for this time. So the president asked for a comparison of our schedule to our peers, and I'll eventually come around to who are our peers. But let's talk. I'm going to leave this slide on. It's affiliation, population, gross domestic product, health spending, and land. And I don't see anybody who's we are alone a lot. But anyway. The CDC schedule of a year ago, of January 2025, I'll describe as methodical, rigorous, and well supported. Changing one cell, one row, one column in that complicated table that Sean showed could take a year or more. Public presentations, oodles of work groups meetings, and then 3 or 4 ACIP public meetings. And then input from practicing pediatricians, practicing obstetricians, practicing adult doctors, family practitioners, and on and on and on. That's how that complicated, well-supported rigor, that's the rigor behind the way we used to do things. And then there would be hours spent on safety briefings of, we looked in this data set and we looked in that data set just in case. And sometimes they'd find things and it would be pursued. That's the way we used to do it. The Monday's schedule, the HHS schedule, is based on a analysis by Hoag and Koldorf, and that quote unquote analysis runs 33 pages and 179 references. It's hot linked from the first paragraph of one of the reports at the HHS website, if you haven't seen it. Now, so 179 references sounds pretty impressive. I personally have written several review articles that had 250 or 300 or more references, so I think I know what I'm talking about. And I'm going to call a paper that reviewed 20 diseases in 21 countries superficial with 179 references, and selective. Selective is the polite way of saying cherry-picked. And selective quoting when it did cite responsible studies. I just looked at a review of COVID vaccine, flu vaccine, RSV vaccine studies, and they found 511 studies that needed to be reviewed. So comparison to peer countries. Several tables have been published. This is table 2 in the Hoag Koldorf paper. I made one. You'll see that on the next slide. The CDC made one. MedPage, I think, shared that a day or two ago. CIDREP at the University of Minnesota has one, and there are others. And the content of them is all pretty correct. I mean, there's not debate about how to describe what other countries are doing. It's just shifting, I'll explain, from being number 1 to being number 7. And we wouldn't accept that if we were in the Olympics. So the Hoag-Koldorf table 2 is on page 15. It's basically a comparison of European countries and Australia and Japan. And I have no particular complaint to the content they put in the cells of the tables. Everybody's basically getting it all right. They did combine all the meningococcal vaccines in one column, and that's a little confusing, but be that as it may. So who is the United States a peer to? If I was going to pick one country, I think I'd probably pick Canada. If I was going to pick a group of countries, I'd say the G7, but not, with all due respect, the G20 countries or even every EU country, or there's a variety of independents, normally Switzerland and Israel over on the far side. Israel's not in the HHS analysis, and curiously, Israel, and it actually doesn't come up in a lot of these tables, but it is extremely like the United States. in regard to vaccine recommendations. So let's see. So Denmark is a peer to its fellow Scandinavian countries, but it's unlike other small European countries like Austria and Switzerland. So let's see. Let's go to the next slide. Why is it not advancing? Should be advancing. All right, let me come back down. No, I can't. Come on. There we go. Sorry. So sorry for the small print. Hopefully you're at a computer and not in a ballroom somewhere, but you look at all the routines. And there are some selecteds in there and there are some blank spaces. But across the top, you see the same list of countries in the same sequence. And you see across the rows the various diseases. It's more or less at the age when things start. First dose is given to kids, more or less. And people don't tend to talk about the 3 rows at the bottom, but those are geographically isolated diseases, and sometimes countries choose to vaccinate routinely, and sometimes they make it some subparts of the population. Um, so let's see. So it used to be that the United States, and in the U.S. column, you'll see the 2025 recommendations scratched out or struck out, and then the revisions in that blue text. The changes are in the blue, in the deeper blue cells. We used to recommend vaccines to prevent more diseases than other countries. Why is that a bad thing? That's what it used to be, and that's the complaint in the HHS CDC recent communications. It presumes that less vaccination is better. In fact, less vaccination means more serious infections, more childhood hospitalizations, more preventable deaths, as my predecessors have described clearly. The United States was preventing more disease. I call that a matter of leadership, a philosophy that favors prevention over suffering rather than coming in with treatment when it's too late. The 2026 schedule takes the United States from being a leader to being a laggard. And using the numbers, you'll see various numbers of how many routine diseases are recommended to be vaccinated against in different analyses. I'll use the Hoag-Koldorf numbers. The US goes from being in first place to being in 7th place in an 8-place league. Only Denmark is more, I'll set up Dorrit, negligent than the US 2026 schedule. And my personal, stats, call out to the publication Stat, which had a similar kind of analysis of the ranking by number in their issue. I saw it today. My personal mantra is prevent all the disease you can and treat whatever's left over. We are moving away from that. So I'll stop there and turn it over to Dorrit, I think.
Great. Thank you. Go ahead, Dorrit. Make sure you turn off your mute, Dorrit.
So the question I'm going to come in with is, are the changes legal? And the short answer for that is, if it gets to a discussion in court on the merits, it's probably going to be struck down as illegal. However, the administration has tried to reduce the chances it will be fully litigated by reducing the practical effect, by trying to make it have less effect on insurance coverage and on liability, while they are clearly looking to mislead people into not vaccinating and maybe using this politically. But I'll also add that they may well not have succeeded in trying to limit the practical effect. And that's where I'll talk about shared clinical decision-making and liability. So why am I saying it's probably not going to survive a court review if it gets to a decision on the merits? First of all, just a second. Come on. Am I frozen?
Dora, you might want to do the use slideshow button at the top there.
Here. Okay. So what's wrong with this? One is the process was bad. As you heard before, this should have gone through ACIP. It did not go through ACIP. The secretary can overturn ACIP recommendation. The CDC director is the first line, but the secretary can do that as well. However, the statute almost certainly requires having ACIP go first and the secretary comes second, and they basically skipped that. Although some of you may think this is a very technical issue, courts are all about technical issue and process really matters. I will add that on the substance, process is also important for good governance. Process assures that the government is transparent, deliberative, and more, and this wasn't. Further, it's probably going to be, and there was no, this was presented to ACIP, but ACIP didn't get to vote about it. Further, this is probably going to be struck down also as arbitrary and capricious. And here I want to give you a mini 1-minute administrative law introduction, which is the standard we use to assess most agency decisions, except for formal proceedings, is the arbitrary and capricious standard, which requires agency to explain what they're doing up to a certain level. And my previous presenters did a really good job setting this up for me. So I'm going to build on what they said, and require the agency also to explain why it's changing its view. So it's not enough to say, this is why our decision is a good decision. You also need to show why the previous decision deserved changing. The next slide you don't need to worry about. It's what I use in administrative law to show the students this is what agencies have to do under arbitrary and capricious. Don't read it right now, don't worry about it right now, but I will refer to some of it. A very common claim in arbitrary and capricious is the agency didn't address an important part of the problem, or the agency's argument was implausible. How does that work here? Why is this probably not going to survive judicial review? Because it's going to probably be found arbitrary and capricious. First, going back to what John just told us, although they said they're equating the US to peer countries, they simply didn't tell us why these are peer countries. You can't just say that. You need to address what makes these a valid comparison. And there are real differences between the countries. Again, John set us up really nicely for that. It's not that they explained it badly. They completely didn't explain why it makes sense for the US to move to this system when the US doesn't have a universal healthcare, doesn't have paid leave, has higher level of poverty, and has other very real differences. So it just was ignored. Ignoring it probably makes the decision arbitrary and capricious. Again, building on what John said, if you're going to go with one of these countries, why Denmark? I mean, again, there might be reasons. I don't think there are. I think my colleagues did a very nice job setting out why there probably aren't. But you have to explain them. And as another legal wrinkle, the agency explanation has to be contemporary. The agency can't get to court and add explanation later. The explanation is going to be judged on it's published with the decision. The Hogue and the Calder memorandum, which just didn't talk about this. They said something about each vaccine. They had, in the memo that John mentioned, the vaccines are discussed from page 19 to 24. What they said was very short, as you said correctly, cherry-picked, and any challenger would correctly say, what about this? What about the risks? Why aren't the risks of hepatitis B and A that Jesse and Sean set out for us discussed? You just didn't talk about it, which makes the decision problematic. They justified this as bringing back trust, and as my colleagues pointed out, that's just unconvincing. You can't just say in your justification something that's completely unconvincing and survive in court. So if it gets to court, it's going to be an issue for them as well. They also didn't, except for mentioning trust and discussing loss of trust, they didn't say why the previous decisions were bad or why they were no longer applicable, and they need to do that to a pretty serious level. So if it gets to the court for discussion on arbitrary and capricious, they're going to have a real problem, because in the time where they had to explain it, they just didn't. They skipped issues that would make it non-survivable. The problem is, will it be possible to challenge this in court? And here, HHS really tried to minimize practical effects. Why are they using shared clinical decision making here? Because they say, under our interpretation of shared clinical decision making, it's still covered by insurance. So you can't say I don't have access to the vaccine anymore because it's not covered. And they also said we're not going to change liability protections, and therefore there's no practical effect. They are running into two problems here. The first is that it's completely unclear that it's true. And let me take shared clinical decision making and insurance first, and then shared clinical decision making and liability. On insurance, we have had in the past insurers pushing back against paying for this shared clinical decision making. And for example, talking about the HPV vaccine, they reduced it to 1 dose. So our insurance is still going to cover 2 doses? If not, that gives standing to doctors and people who want to get 2 doses and now have a problem. On liability, anti-vaccine groups have already said, and there is actually an argument there, although it's not foolproof, we're going to challenge to say you have to remove vaccines that are under shared clinical decision-making from the vaccine injury compensation program. If that happens, then companies will have right to sue. Claimants who want to go through the program, which is actually easier for people who want to be compensated in the courts, will have standing. States that are now really facing loss of vaccine from the market, if manufacturers step back, have standing. So that's some of the practical issues. And as Sean and Jesse pointed out, there's also real effect on uptake. We've heard about, for example, places canceling drive-through clinics for COVID and flu because they think it's not compatible with shared clinical decision-making. There's substantial confusion, and that can reduce uptake. And that would mean that people have standing and they can bring all the very strong arguments we've just talked about. Finally, this week as well, on the good news side, in a case by the AAP against Kennedy, a court found that the AAP has standing to challenge COVID-19 vaccine, which was moved to shared clinical decision-making, on the ground that it directly affects AAP's work because AAP counsels on vaccine and now it has to do more. And its members are now facing additional financial consequences, and Kennedy threatened them with litigation. So in spite of the efforts of AHCJ, this might get to standing and maybe challenged in court. And if it is challenged in court, they're probably going to have a problem. Thank you, and I look forward to questions.
Thank you for that, Dorit. Okay, we've got a lot here and a lot of questions. I'm going to start with some things that we put in the chat there. Someone asked about the Cochrane review that Kennedy referenced, claiming that the flu vaccine was not effective. And the comments that are in the chat there are ones that I personally wrote, Tara Haelle, so I would not use those as quotable simply because I'm a journalist and not an expert. I mentioned it because I was familiar with it, but I would like Sean to address that particular review and what the problems are with it.
Yeah, I mean, I'll just start by saying it's similar to the strategy that has used over and over by the secretary and frankly anti-vaccine activists, which is cherry picking to support their conclusion. And so that they cherry picked a particular line in a particular article to try and support their conclusion. The other thing I would say is Cochrane reviews aren't perfect, and there were some problems with that particular review that I won't go into detail on. But the bigger issue is it's quite old. It was published in 2018 using data through 2015 using, I'm mixing up my dates here, but I think it was 2018 using data through 2013, ignoring literally dozens of studies since then showing the effectiveness of influenza vaccine at preventing hospitalizations in children, deaths in children, preventing community transmission, household transmission, school absenteeism. There are dozens of studies that I can share after this. If you'd like, I can put a nice long list in the chat, basically showing that what they're doing is cherry picking to support their conclusion. But the evidence is actually out there that the vaccine is safe, it's effective, and it prevents hospitalizations and deaths.
And I'm going to follow on with another question for you from Grace Abels asking, again, addressing that shared clinical decision-making, which is so confusing. We know what that means from a policy standpoint, but what does that look for parents and doctors? Like, what will parents have to ask for the vaccines? Are the doctors going to bring it up? Are they, Do the doctors have new legal risks? Like, what does this actually mean in practical terms?
Well, so I'll just tell you, it's chaos. There's no precedent for this. So the only vaccine really that pediatricians have confronted before that had this shared clinical decision-making recommendation prior to this administration was Serogroup B meningococcal vaccine. And what we saw with that vaccine is pretty low uptake. I believe roughly 30% of people who met the category got the vaccine. What I have heard from a lot of clinics is they either decide to not even stock the vaccine and not even offer it, or they decide to just recommend it routinely because they can't deal with the long conversation. So the issue, that I've heard also from many clinicians is when a shared clinical decision-making recommendation would come from ACIP, they would say, you guys are the experts. You're supposed to tell us what to do. If you can't, if you can't decide if they should get the vaccine or not, how are we supposed to figure that out in a 10-minute office visit, right? So it's really confusing. So now what's happened is they've put all of these vaccines that are routinely recommended that have very clear benefits outweighing any risks into this category, and nobody knows how to handle that. Now, again, many organizations are pointing to the AAP schedule, are continuing to recommend these routinely. A lot of states are doing that as well. And so we're trying to get the message out to those clinicians. Don't change what you're doing. We're trying to get the message out to as many parents as we can that this move was misguided and wrong, and you need to just trust your pediatrician, follow the recommendations of the professional societies. But it's going to be a real challenge, and it's created a ton of chaos. I can't really comment on the legal. I mean, I could try, but I've got a better expert in the room on the legal aspects of it. But it's a real challenge that we are grappling with right now. It is creating chaos.
Thank you for that. And then another person asked about who covers the disability community. Emily Watkins asked whether the longer term outcomes of these changes to these guidelines could be increased rates of disability or more people using disability services over the course of their lifetime. I figured that might be something Jesse could respond to.
Yeah, I think absolutely. Hepatitis B, by not vaccinating children and infants, there are going to be more infections. And a substantial number of those infections, majority of them, in fact, will have chronic liver disease and need intensive monitoring, if even monitoring for cancer and cirrhosis. And then, as Sean and I said, when you're infected near the time of birth, a quarter will go on to develop life-threatening, usually fatal complications like cirrhosis and cancer. So even for that one alone, or if you get meningococcal meningitis, a quarter of people, first of all, 15% won't survive despite antibiotics, and we have increasing antibiotic resistance. And then on top of that, a quarter of them have lifelong disability, some with loss of limbs. So, some of these diseases you can recover from, but even from flu, a bad case of flu, a bad case of Hep A, which usually most children will recover from, they can have months of effects on that child or on the family. So I think this is stupid and harmful for patients. It's also economically extremely wasteful, and it just makes no sense from any of those points of view.
Two questions for Dorit, and these are both, actually, one of these might be for John, I'm not sure. The question for Dorit from Eddie Bresnitz is how this might affect VICP, the Vaccine Injury Compensation Program. We'll do that one first, then I'll ask the other question.
I just want to build on what Sean said, just to add a point about the reason Sean mentioned that doctors may now refuse is previously the AHHS position was that if you're using the Vaccine for Children program, you have to carry all the vaccines in the program. And one possibility is that you don't now have to carry the shared clinical decision making, and you can still be part of VNFC and carry the others. On the Vaccine Injury Compensation Program, so the first thing is AHHS position, and I think they're right, is there aren't going to be any immediate changes. So there are vaccines right now on the Vaccine Injury Compensation table that are affected by this. And to change the vaccine injury table, you need to go through a lengthy rulemaking process that includes commenting and an oral hearing. So it's not going to be immediate. However, there is an argument. So the law says that to be under VICP, a vaccine needs to be routinely recommended for children and pregnant women, or pregnant women. And there is an argument that shared clinical decision making is not a routine recommendation. There are other arguments. It's never been litigated. So if the secretary wanted to remove those vaccines for VICP, he'd have to go through the process, but he could remove the liability protection and remove the option of plaintiffs of going through VICP and send everybody to the courts, which may mean manufacturers will leave the market. So it could happen. It won't be immediate. And the secretary, I think, will be careful because he doesn't want anyone to be able to easily sue, and that would give people standing.
And then the other question, which was from Isaac here. Sorry, I'm trying to keep up with these questions. Isaac Benowitz. The decreased availability of the flu vaccine in clinics is concerning for access. How many states have pharmacist administration of the influenza vaccine without a doctor's order? Does anyone, John, I was guessing you might know that.
I don't know quickly with a
Okay.
number, maybe 10 to 20, something in that range. But states
Okay.
are moving to make the pharmacist's ability to vaccinate more akin to standard of practice as opposed to any one body.
Okay. Another question for you, and this might be something George can add to. Will the outcomes for vaccine production, access, and whether or not the manufacturers might try and get out of the business because of loss of government contracts or expected sales, do we have any sense of what the financial fallout could be from this?
Well, lower demand means less revenue. That's pretty simple. The piece I think that's worth mentioning is what about researching additional vaccines? And because that's a lot more discretionary when manufacturers are choosing where to invest. Should we try to have a cytomegalovirus vaccine, the disease that caused my cousin's child to be deaf? Should we have other kinds of vaccines? And if it's an unclear, uncertain situation, hey, companies can invest in other products. Let's invest in oncology. Let's invest in cardiovascular disease or whatever instead of that risky infectious disease space.
Question for Sean. Can you address how might these changes affect how clinicians procure, finance, and provide their vaccines? And that's a question from Sarah Markle Elder, and then I'm going to combine that with a question from Laura Studner. Can providers now just point to the AAP schedule and ignore well, she didn't say ignore, but not listen to the CDC recommendations? Do they have the authority to do that?
Yeah, so both somewhat complicated questions. But in terms of procuring, financing, all that stuff, it's a very complicated process that, it depends on if you're in a health system, depends on if you're a private practice, federally qualified health center. There are a lot of different practice settings that this is going to impact in different ways. But the short answer is yes, it's probably going to affect that because if they see, for example, demand go down for their shared clinical decision-making vaccines, they may just say, this isn't worth me stocking this vaccine. I have also a lot of concerns about there are a lot of small individual private practices, particularly family medicine, where stocking vaccines for children can be really challenging to start with from a financial standpoint for a variety of reasons. And for those that, either are, just thinking about starting to stock vaccines, they, probably that's off the table now because it's going to be even more challenging. For those that are sort of hanging on by a thread, continuing to try to give vaccines, they may stop because this is all making vaccine delivery more challenging for sure. There are a lot of other things that this may touch, but in terms of the ordering and things like that. But I think the short answer is yes. I think I could spend too long talking about this right now. But yes. In terms of the second one, yeah, I mean, that's what we are recommending is that pediatricians, family physicians, all clinicians who deliver vaccines follow an science-based, evidence-based schedule, the one currently endorsed by AAP, and then you've seen other professional societies endorsing it as well. which, essentially goes back to the vaccine schedule as of, November 2024, January 2025, prior to these changes. And so, yeah, yes, in most cases, I think clinicians can, but there are certain situations that may make that more challenging. And unfortunately, I think this may come down to somewhat of a red state, blue state thing, in terms of what this also gets complicated. Like there's the VFC program that's administered at the state level. They may treat ordering these things differently because some are shared decision making, some aren't. That may, like in my state where I am in Colorado, our state health department really isn't going to change anything based on this. They have already put out a statement that we are going to follow the AAP schedule. Many other states are doing the same. A lot of states aren't doing that. So what's going to happen in those states? I don't know. It's really challenging right now.
Two more questions. We're probably going to go a little bit over time on this, and I've confirmed with the speakers that most of them can do that. Sean will have to leave us before some of the other ones, so I'm going to ask you two more questions, Sean. One is how the U.S. came up with HPV as one dose and whether that was ever approved by the FDA. And the other question was whether or not, could you give some examples of situations where children can get hepatitis B from a household contact? And I want to mention on that one, I put in the Q&As, if people want to look at those Q&As, a link to the hepatitis B post that I wrote for AHCJ, which includes links to some studies about household transmission that does not involve knowledge of fluid exchange, such as dried blood. But I'll let Sean actually address that.
Sure. Sorry, the first one again.
So sorry, the first one, HPV. Sorry.
Yeah. So HPV. Yeah. So first of all, that is an off-label recommendation. It's not FDA approved. That is not the big deal here, because there are other off-label recommendations in medicine, particularly in pediatrics. We do things off-label not infrequently. But the bigger issue here was the process. Because normally what happens is you go through the evidence, you weigh the benefits and risks, you look at a lot of different potential pros and cons, you look at the downstream impacts of this policy decision, and none of that was done in this case. So, you may be aware the Vaccine Integrity Project is doing an evidence review on that. We have been at AAP, we've been discussing this. I was on the HPV work group before its dissolution. And so this is something that we have discussed. And as I mentioned, other countries have done this, but it's really the process by which they went about this that was the big problem with that particular recommendation. Now, for hepatitis B, yeah, I will say in a lot of cases it's unknown. And what I want to say is that hepatitis B is actually an incredibly transmissible pathogen. So when you hear these talking points of like, well, it's a sexually transmitted disease and it's among IV drug users, we don't need to worry about it. That while those are two very high risk category, like those are two high risk things, that's not the only way it's transmitted. It can survive on surfaces for quite a period of time, can be transmitted by things like, sharing a toothbrush, sharing utensils, simple things like that, tiny cracks in skin that you don't even know are there. So simple things that, a parent caring for an infant might not even be thinking about, and then they transmit it to their child. And so that many of the people, in fact, who have chronic hepatitis B in the US don't know where they got it. They have no risk factors. They just happen to get it and they don't know where they got it. So this idea that it's only high risk, these people, and there were some terrible pieces of that discussion in the last ACIP meeting about, who gets hepatitis B that were just, really unconscionable. But anybody can get hepatitis B.
This is a question for either of the physicians here. With the new schedule, do you expect, in your professional opinion, that we'll start to see an increase in diseases or infections resulting from these decisions?
Let me start with that. I'll start with that. Yes, we will. There's no question in my mind. Some of these are going to be short term. We're already, just look at measles and pertussis. We've seen hits in vaccine confidence and just the small dips that we're seeing in vaccination coverage, even though the vast majority of parents are still vaccinating their kids, the small dips we're already seeing the impact of that. Other things are, for example, rotavirus, that could come back pretty quickly if we saw a big dip in that. We might start seeing more hospitalizations. Some of these things will have much longer term impacts. So if we see dips in hepatitis B vaccination coverage, the impacts of that are going to be more years down the road. Similarly, for vaccines like HPV, where the consequences are much further down the road. But there will be absolutely be impacts, some short term, some longer term, and then of course, not even mentioning all the diseases we no longer even see in the U.S. Those could come back. And I should more broadly say that these shared clinical decision-making vaccines are not the only ones that are taking a hit in confidence right now. Most of the general public is not following this all that closely. All they're hearing is, wow, there's controversy about vaccines. And I'm hearing from pediatrician after pediatrician that I'm having families refuse vaccines saying, well, there's so much controversy right now, I just want to wait. They don't know the details of what's going on. They're just refusing all vaccines. And so the actions of this administration are having very real consequences in very real time.
This is a question from Grace Abels at PolitiFact. Is it possible this change could allow for new studies to be conducted that are currently considered unethical? And I think we're probably thinking where a child is given a saline placebo instead of a current vaccine. And I think we were already seeing that with that hepatitis B study that was initiated somewhere overseas, and I don't want to say the wrong place.
Guinea-Bissau.
Thank you. So what could this lead to? Well, I don't know how many of our attendees know what equipoise is, but I guess could this shift equipoise?
I'll start with that. When I was in the Army, I oversaw an office that supported 10 institutional review boards, research ethics committees, and their job is to adjudicate: am I protecting the volunteer? And I would say, despite all this HHS stationary, no IRB is going to say, oh, suddenly it's okay to give a placebo. Suddenly it's okay to withhold a effective vaccine that prevents disease from that little kid. No IRB is going to do that I know of, that I would respect.
Is it possible in some states, it appears that it's possible to talk to a pharmacist and have that count as shared clinical decision making? Is that an option for parents? And this might be a state-based question. I don't know.
It's not. No, CDC, it has been on the CDC website.
Okay.
Pharmacists are fully competent to engage, were fully competent to engage in shared clinical decision making, and still are.
Okay. And this is a question for either you, John, or possibly Jesse. Who has a clear financial benefit from vaccination? I'm assuming that there's a very big number in public health in terms of lost, parents not missing work, kids not missing school, hospital costs. Like, can you talk about the financial benefits of everybody vaccinating?
Well, so is it Ben Franklin, the ounce of prevention is worth a pound of cure? So cost effectiveness is part of this equation, and then it's from whose perspective? From the parent's perspective, from the health network perspective, from society's perspective, and there are economists who do this for a living, but essentially every one of the vaccines we're talking about is effective from each of those perspectives, and is a good value, is a good buy. Let me stop there and see if that's the question.
Yeah, I think that state level challenges to school vaccine requirements. Dorrit, how could these changes affect that? Could parents try to use these federal guidelines to claim that certain state level vaccines should no longer be required?
So state level requirements are laws. You need to actually change either the law or the rule in response to that. What I would expect is that this would be used as a political leverage to pressure states to change their required laws, but it could be used that way. I will also add that some states have a connection to ACIP recommendation for the school immunization requirements, and in those states, parents may ask to change, but the change won't be automatic. You would actually have to change the school immunization laws for this to have an effect on the ground.
Yeah, and I would, this is Jesse, I would add that this is a great thing for journalists to track, because in many states now, initiatives are underway to try to reduce school entry requirements. And for example, with hepatitis A, if less kids are immunized, we are going to see again what used to be seen 30 years ago, which is outbreaks in schools. And kids are going to come home horribly sick, and parents adults get even sicker from hepatitis A, and adults are going to get sick. So I would say making local and state people aware of these initiatives and their potential harm is going to be really, really important, because I think there is going to be a major effort in that. And before people realize it, they will have the safety of their school environment and their children affected by those kind of changes.
Another question for Sean. I'm trying to prioritize ones for Sean since I know he needs to go shortly. In the Hoag-Koldorf assessment, they support the move to shared clinical decision-making by stating it is not always possible for public health to clearly define who will benefit from a vaccine, who has relevant risk factors, and who are at risk of exposure. Can you address that claim?
Well, I mean, that was what ACIP was for, up through April of 2025, was to go through weigh all of those benefits versus risks, not just from does the evidence, does the scientific evidence support it, but considering what are the downstream consequences, considering the cost, et cetera. And for every vaccine in the schedule, that has essentially been done already. And so, and it was very clear that the benefits outweighed the risk. Now, you could argue some may be more cost effective than another in terms of dollars spent, but in terms of like lives saved compared to, the potential risks of the vaccine, it was very clear for every single vaccine on the schedule that the benefits outweighed any risks.
And just another confirmatory question from Bindi Crouch, just to make sure these vaccines currently are covered by VICP at the moment, and so far that's going to remain so unless they get taken off the table, right?
Yes, they are covered by VICP at the moment, all of them, and it'll remain so unless it's taken off the table, which will require rulemaking.
Okay. From a quick question, clinic nurses, they can discuss shared decision making as well, correct? Anyone?
Can I say something on that?
Yeah.
It's completely unclear that shared clinical decision making actually requires any difference to the informed consent practices. I think Sean addresses some of that, and you get the impression that it requires more discussion, but the reality is you already need some informed consent for everybody here. Anyone who can get informed consent from a vaccine can probably still have it under shared clinical decision making. I should be more careful because John already addressed pharmacists, but pharmacists' scope of practice is defined more narrowly in many states than other places. But that probably doesn't come up on this one. If you can get informed consent for a vaccine, I mean, you need informed consent for a routine vaccine as well. Sean emphasized that this discussion already happened.
We get last year, every 100% of people in the United States who got vaccinated gave consent. I mean, or their parents did.
Yes.
And it's not new.
Let me just say one more thing about that, and then I probably should get off because I got to go deal with another dumpster fire. But so shared clinical decision making is a piece of the evidence to recommendations framework that ACIP landed on as an option roughly 7 or 8 years ago. And let me just briefly give the background of how vaccine recommendations had worked there, because this really matters for where we are today. It used to be there was recommended vaccines, things that weren't recommended, like, say Japanese encephalitis for the general population or whatever. And then there were permissive recommendations for certain vaccines where it was available, but they didn't the benefits weren't clear. They just said, but you can get it if you want it. And then they moved into what they called Category A and Category B recommendations. So Category A recommendations meant they were routine for everyone in the population for whom it's recommended. Category B were, basically less robust. And they used that recommendation first for that serogroup B meningococcal vaccine that I mentioned. Very expensive from a societal standpoint to recommend the vaccine for the entire population. So it didn't make sense to do that, but they wanted the vaccine available for people that wanted it. And so that's what they did then. Then they moved into what they called shared clinical decision making. And they got some criticism for that because it's shared decision making is a specific body of literature and field of shared decision making that is a bit different than how ACIP was using the term. It's really meant for, in general, for what are called preference-sensitive decisions, where there's no clear right medical answer. You might have a decision between a less invasive procedure and a more invasive surgery, and there are pros and cons to both, and you talk through that with the patient. With vaccines that are recommended routinely, the benefits far outweigh the risks, and they aren't appropriate for that type of shared decision making. And so when they went to this framework, they were really using it at the time to make vaccines available for people that wanted them, but where there wasn't clear benefit. And then there was a lot of confusion, again, after that for how clinicians dealt with that. And that's why I say clinicians really didn't like that kind of a recommendation because they weren't sure what to do with it. And there was never really very clear guidance, even prior to all this, on how you handled those. So now they are using this as sort of a talking point to say we're restoring trust in the doctor-patient relationship, which is total nonsense, right? This is just creating tiers of recommendations that make vaccines more difficult, is just one more step in the ongoing effort to dismantle the U.S. vaccination program. So let me stop there, and then I should probably jump off because I should say we already do shared decision making all the time, all day, every day, as I mentioned, right? We already have these conversations.
Before you go, Sean, real quick, because of that change a few months back where the CDC claimed they changed their vaccines do not cause autism page, which dismisses the whole idea of a refutable hypothesis in science. Douglas Morier asked for panelists to recommend their favorite resources available for communicating general health media literacy and questions about that for the average patient. Do you have some specific sites that you'd like to recommend?
Oh, plenty.
This is your chance to say healthychildren.org.
Yeah, I mean, the healthychildren.org is good. They're updating that all the time. And then immunize.org is a great resource. What I generally say is that academic medical centers in general can be trusted. The Children's Hospital Philadelphia Vaccine Education Center is a very robust resource. The regular American Academy of Pediatrics website is a great resource. There are lots of great resources, but unfortunately there are a lot that masquerade as good resources that are really actually not very trustworthy. I could go on and on. I can share a list with you after. Lots of great resources out there. Vaccinate Your Family, Voices for Vaccines. I could go on and on, but lots of great resources. You don't need to create new content. The stuff is out there. But we're going to need it more than ever at this point.
All right, and I'll let you go now. Thank you. A question for Jesse, since you're a physician as well. Is there any sense of how many physicians, pharmacists, et cetera, might actively discourage vaccinations in shared decision making? Is that something that might actually occur?
I would doubt it unless the requirements become clearly draconian or difficult. I mean, I think the challenge is that whether you're a pharmacist, a nurse practitioner, a PA, a physician, everybody is over busy, and there are not sufficient financial incentives or reimbursements to spending extra time with patients, and nor is there time. So I think it's another disconnect between this idea and the reality of what medicine is. Anytime you make something more complicated, it's going to be, difficult to bring off, and it's going to affect access. But no, I think most people want to do what's right for the patients. And as everybody's been saying, we already do shared clinical decision making. I have an outpatient clinic every week, and I always talk to my patients who are recommended to have or getting vaccines about them and answer their questions. What I will want to reinforce is that Sean's comment about these kinds of things shaking faith in vaccines in general. So, I just had a patient, for instance, who's in a high-risk group, elderly, who should get COVID vaccine. And this individual, I asked, do you have questions? Because he had declined it. And I spent extra time with him and asked, and he just simply said, because RFK said I shouldn't do it. Well, in fairness to RFK, he didn't say that, but that's how this is interpreted out there in the environment. So we're seeing a toxic slush of inaccurate information that really is confusing people, and if it's allowed to continue, will ultimately cause harm. It's not going to be overnight. Many people who have the wherewithal will insist on getting their kids these vaccines, and I'm glad of that. But there's going to be a lot of people who don't have the wherewithal or have doubt. And over time, if we have less people immunized for these diseases, we will see more disease. And we're not the same as Denmark.
Following up on that, someone suggested in the questions that the vaccines influenced by these changes are of such little consequence to the vast majority of children. John, could you address how much consequence these vaccines have to children?
Well, so if we could anticipate, if we could predict who's going to get infected, then we could target the vaccine. The problem is you can't. It's just which of my grandchildren will get hospitalized with influenza? I don't know, and I can't know, and nor all the other grandkids out there. And so we vaccinate a lot to prevent, I forget the statistics, but tens of thousands of hospitalizations, and last year 200 deaths. Is it okay to have 200 deaths from influenza? 200, such a parents, I think, will disagree with you. So these diseases are serious diseases. They are sometimes inconvenient, but they can be very serious diseases.
The recommendation to administer an HPV dose, only one, is an off-label use. Would that mean that nurses could not administer it under a non-specific standing order? And my guess is, since you're talking about the second, it's just not giving a second dose. So they could give one dose and it wouldn't influence whether you get a second dose. Is that correct?
Yeah, I think that's how many angels dance on the head of a pin.
Okay.
It would be off label. What's the off label standard in that state? Under what compact is the nurse operating? I think that's a local double check
Okay.
yourself thing.
A question for Dura. Historically, courts might have struck us down, but in the current climate and looking at recent decisions related to the Trump administration, do some of the things that you address, like the arbitrary and capricious, are they going to hold? Are they going to pass muster? Do you think it's actually going to work, or is that asking you to be? That might be sort of a crystal ball question. I don't know.
The Trump administration has been doing very badly, as in dismally, in the court on arbitrary and capricious review. Where they've had successes is more in the constitutional effort and the level of presidential power. When it comes to arbitrary and capricious review, they are not doing well at all. And that's across the board, from judges appointed by any president, including judges appointed by President Trump. And by the way, that was true in the first Trump administration as well, and its intention. Historically, agencies under either administration had a 60 to 70%. The Trump administration has over a 90% loss on arbitrary and capricious, and that's because even if they're doing things that are legal, they're explaining them really badly. So right now, arbitrary and capricious, they're just not doing the work, and I think that's going to stay. But you're right that our legal system is only as strong as the judges are willing to uphold it, and we're going to have issues in other areas, such as constitutional issues.
Someone mentioned in the comments that there are 29 states where pharmacists have independent authority to vaccinate. I would fact check that, but that's just a statement for people to be aware of. Someone else asked about how the dedicated CDC staff who are hanging on there are responding to these changes. And I know that our panelists are not able to read the minds of people at the CDC. So I'm going to direct you to one of our previous webinars where we heard from 3 former staff members of the CDC about that. And all 3 of them are eager to speak with journalists. Dimitri Daskalakis has been particularly outspoken on this. And he did a speak with Jeremy at Inside Medicine. So I would encourage you to look at those. Another question for Dorit. Is there a way to prevent this stuff from happening again in the future? Like, is there legislation that can be passed to make it harder for what's currently happening to happen, or are the current statutes adequate and it's just a matter of making its way through the courts?
The answer is a little complicated. The first thing is that in a democracy, if the administration wants to do stupid, irrational, and crazy things, judicial review can help, but if they're willing to explain it to the level of the courts, they are probably going to get away with it. The second point is legislation can address it. For example, Congress can demand go through this process, and to some degree, that's the second one. For example, Congress has set up vaccine recommendation to go through ACIP, and it hasn't been followed. And this is a place where the courts can step in and address it. The third part is a constitutional point, which is over the past 2 decades, the Supreme Court has changed the balance between civil servants and experts and political appointees towards the president, toward the political appointees. In other words, right now, constitutionally, the court expects the political appointees to have direct control over every decision. That won't be changed without a constitutional amendment or a change in the court, a change of the court's interpretation. And it's in tension with the way our jurisprudence worked for decades. That's a little beyond this specific issue. But right now, under Supreme Court jurisprudence, the balance for our administration is political appointees have the higher authority, and experts have the lower authorities. If we want to change that, we might need to change our constitution.
What should public health efforts be doing right now in the broad spectrum? And this is a question that I assume is probably asked by someone in public health, but journalists might want to look into this to see what local organizations are doing in their area. Should they be focusing on herd immunity to offset the potential decline in vaccinations, or what's a response that we'd want to see?
Every vaccination is an individual set of decisions between the provider and the patient or the parent. And so we should support and reinforce and enable the healthcare providers, pediatricians, and many others with the facts, with the evident reason for the evidence, and the communication tools to have meaningful, trustworthy conversations with America's parents.
And then, Dorit, did you want to add something to that? You had your hand raised there.
Just a reminder, speaking up, going to the court, supporting court decisions with amicus briefs. For example, in Kennedy versus AAP versus Kennedy, Defend Public Health submitted an amicus brief that was cited by the judge and health. All of this can help. So if you can communicate also with your local policymakers, work to preserve the statutes that exist in the state and to avoid bad statutes, and see where you can join litigation, that's also helpful.
Okay, I think we actually have gotten to most of the end of the questions here. Someone had asked about the elderly going unvaccinated because that was a concern. That's a little bit far afield of this since we're focused on children here, but if John or Jesse wants to address that.
Yeah, tens of millions of American adults are vulnerable to a serious infection with influenza, with COVID, with RSV, with pneumococcal disease, bacterial infection, many others. And so please get yourselves vaccinated, get your parents vaccinated, and everyone you love should be vaccinated.
Okay, we got to the end of the questions. I don't think that's ever happened on one of my vaccine webinars. Any final remarks that Dorit, John, Jesse, that each of you would like to make? You're welcome to. Go ahead. We'll start with Dorit if there's anything else you want to add.
I kind of want to end on the point that John made about getting yourself vaccinated.
Great. All right. And so I guess, John, that was probably your final. Jesse, any final comments here?
I did want to respond to one comment or question you passed along, which was sort of minimizing the impact of influenza more generally and the impact of vaccine. And, although it's a complicated topic, what I would say is we need better influenza vaccines. Part of what's going on with all this casting doubt in vaccines is going to lead to less investment in better influenza vaccines. In fact, the U.S. cut its investment in influenza vaccines, including the RNA vaccine, which seems to have higher efficacy than the current influenza vaccines. So what I wanted to say is that flu vaccine is imperfect, but despite what the memos that just came out said, study after study supports that there is at least some benefit in protecting against hospitalization. And don't say that influenza is not a consequential disease when something like 45,000 kids are hospitalized for it. That is a huge burden for that child and that parent. So even if the vaccines aren't perfect, evidence suggests they may be helpful, so why not take advantage of that? And let's move towards a next generation of vaccines that will be more effective.
Thank you. Oh, did someone start to say something? I'm sorry. Okay. Two things I want to mention. These are personal for me personally, so they should probably not be quoted since I'm a journalist and not an expert. But when my family members ask me whether to get the COVID and flu vaccines, I tell them not to get the vaccines for the sake of preventing those diseases, but so that when you get those diseases, you don't end up in the hospital or a graveyard. That's how I speak to it personally to people. And another personal thing that I saw Jeremy Faust wrote in a recent Inside Medicine post, that when he's talking to people, he says the politics has changed, but the science has not. So those are two little nuggets that I think people might want to consider. Thank you very much, everybody, and thank you for staying longer. I really appreciate the huge attendance that we've had and our guests speaking on all of these very complex issues. Again, this webinar is on the record and will be publicly posted later on today. If you have any questions that you did not get answered or would like to be put in touch with any of the panelists, you can email me personally directly at THAELLE@gmail, and I can help do that connection. Thank you again for everybody who came in, and have a decent weekend. Take some time off, unplug, touch grass. I hope everyone has something restful planned. Take care.